Welcome back to the deep dive. So, today we're getting into something called aspirin-exacerbated respiratory disease, AERD for short.
hmm
You might also know it as Samter's Triad. Basically think asthma, nasal polyps, and, well, a real problem with aspirin and similar drugs.
Exactly. It's that specific trio that's the key here. Asthma can happen alone, polyps can happen alone.
Sure.
But when they show up together with that aspirin sensitivity, it points to something specific going on. We'd all mentioned it way back in 1922, but Samter really nailed it down in 67.
Okay, interesting history. But how common is this specific condition, AERD?
Well, in the general population, it's not super common, maybe up to, say, 0.3%.
Okay.
But here's the thing. If you're an adult with asthma, that number jumps quite a bit. We're talking like 5 to 10%.
Wow, that's a significant jump.
Yeah, and we also tend to see it more often in people over 40, especially those who don't have the usual kind of allergies, what we call non-atopic.
Right, non-atopic. So less of the standard pollen or dust mite allergies, maybe?
Pretty much, yeah. Less IgE-mediated stuff.
Got it. So for this deep dive, our mission is really to get under the hood of AERD based on the medical understanding we have. What's the actual mechanism? What's driving it?
Okay, so the core issue seems to be how the body processes something called arachidonic acid. Specifically, it involves an enzyme, cyclooxygenase.
Cyclooxygenase.
Aspirin and other NSAIDs like ibuprofen, they inhibit this enzyme. They block it.
Right, that's how they work for pain and inflammation generally, isn't it?
Exactly. But in people with AERD, blocking that cyclooxygenase pathway has this knock-on effect.
Okay, like what?
Well, the arachidonic acid doesn't just disappear. It gets sort of shunted, rerouted down the lipoxygenase pathway.
So blocking one road forces traffic down another.
You got it. And the result of that is a big increase in the production of these inflammatory molecules called leukotrienes.
Leukotrienes, okay, I've heard of those in relation to asthma.
Yep. They're major players in airway inflammation. So you get a flood of these leukotrienes, but that's not all.
What else?
Blocking cyclooxygenase also means you produce less of something else, prostaglandin E2.
Prostaglandin E2, what does that do? Or what happens when it's low?
Well, prostaglandin E2 normally helps keep certain immune cells, mast cells, stable.
Okay.
So when PGE2 levels drop, these mast cells become kind of unstable, more likely to degranulate, basically, release histamine.
Histamine, right, the classic allergy chemical.
Exactly. So now you've got this double whammy hitting the airways and nasal passages.
So
Way more leukotrienes and more histamine release.
that sounds like a recipe for serious inflammation.
It is. That combination ramps up vascular permeability. Think of like blood vessel walls getting leakier.
So the fluid leaks out.
Yeah, fluid leaks out into the tissues, causing swelling, edema.
And I'm guessing the chronic swelling and inflammation in the nasal passages is what leads to the nasal polyps and AER.
Precisely. And here's something really interesting. The polyps and AER aren't just any polyps. They tend to be, well, extensive, much more widespread.
More severe.
Yeah, if you look at CT scans, the scores indicating how bad the polyps are usually significantly higher in AER patients compared to people with polyps but without AERD.
Wow. Okay, so that must make them harder to treat, right?
But absolutely. They're known for being more aggressive, and unfortunately, they have a much higher tendency to come back after treatment.
Ugh.
There was this cohort study looking at people who had sinus surgery, SES, functional endoscopic sinus surgery, because medication wasn't cutting it for their polyps.
Okay, what did they find comparing the AERD folks to others?
It was pretty stark. After 5 years, in the control group, no asthma, no aspirin issues, 84% were still polyp-free.
Pretty good.
For those with just asthma, it was 55%. Still okay. But for the AERD group, only 10% were polyp-free at 5 years.
10%, that's a huge difference.
Massive difference, and it gets worse.
Oh, no. What about longer term? Say 10 years out.
Okay, get this. At 10 years, control group still doing reasonably well, 78% polyp-free. Asthma group down to 45%. The AERD group,
Let me guess, lower still.
0%. 100% recurrence rate within 10 years for the AERD patients in that study.
100%. That's just incredible. And incredibly frustrating, I imagine, for patients.
It really underscores that AERD isn't just asthma plus polyps plus sensitivity. It's a distinct clinical entity. That underlying mechanism we talked about drives this really severe, really recurrent disease.
Right. So wrapping this up then, AERD is this specific triad, asthma, polyps, aspirin issues driven by that cyclooxygenase inhibition, the leukotriene surge, the histamine release, leading to these really extensive, stubborn polyps with, well, frankly, dismal long-term outcomes after surgery.
That sums it up well. It's a challenging condition.
So a final thought to leave everyone with.
Yeah, considering how specific this inflammatory pathway seems to be in AERD, this whole cyclooxygenase, lipoxygenase, leukotriene cascade triggered by aspirin, it really makes you wonder, doesn't it? What's the potential for developing treatments that specifically target that pathway? Could we find something more effective for AERD compared to the broader treatments we use for other types of asthma or polyps? It highlights how different inflammatory processes can be, even when they look similar on the surface. Something to think about.